Thank you very much for the opportunity, Dr. Tarun, especially Fistulacon. In every part of India now, Fistulacon is being organized because every wall of the railway station in India has got Bhaganda written on it. So it requires that much attention. The younger surgeons might be confused why so many procedures, and I want to put things perspective in my experience. So FILAC or FILAC is the term used for fistula laser closure. So just like single incision laparoscopic surgery came and almost disappeared. So every term or every technique is not here to stay. So I'm not going to talk about glorifying this word FILAC because this is, as my previous speakers also said, no more exists as a sole procedures reliable for managing a problem as difficult or as challenging as fistula for surgeons. I bring compliments from my NG360 Academy and Maxis Hospital, Patparganj. Regular trainings in laser proctology we have. So, we have plethora of surgical options, starting from the most conventional to the most advanced. I was happy hearing the modification of Dr. Tarun for WAFT, because WAFT we know the challenges, high incidence of recurrences. He was happy saying sit on. So I learned this with WAFT we can do if we want to. As Dr. Singla said, step ladder pattern for the cyst trunk operation. So these are very good learnings. And Dr. Pawan said, why to penalize the whole class for a single student who is mischievous? This is what is minimal invasive procedures bring for management of fistula in general. We have the whole plethora, whole spectrum of fistula. It's not a simple problem. It may be curved, it may be horseshoe, it may be high, low. So, because we are in the Delhi, city of Delhi, the capital city, architecture of our own Connaught Place is very much similar to the anal canal and the surrounding fistula. If you look at it, Connaught Place closely, the central park of the anal canal here is just like the anal canal, the central park. And then you have the inner circle, the internal sphincter. You've got the outer circle, that is the external sphincter around the anal canal. And you have these got radial roads connecting from inner circle to outer circle. They are the fistula tracts, starting from the crypts of anal glands. So the complexity of fistula doesn't stop here. It is not as straight as this, as somebody was asking very rightly, the tracts are curvilinear. So the tracts, they can connect in this manner circumferentially in any configuration. This is where the challenge of fistula comes. This is the picture that I use to help my patients understand the complexity of this disease, because fistula management is a name spoiling surgery. It brings more bad name to the surgeon than the enhancing their image, because recurrence can be multifactorial. So if we talk about application of FILAC, that is laser for fistula, it is not only laser. We need to combine some of the other procedure to manage the internal opening of the fistula. Because the principle of management of fistula, what I have understood, is disconnecting that opening from the anal canal for the tract. If we can achieve that by any method, then only the procedure can be successful to whatever extent. So we do most of the time combining a ligation of the tract in the intersphincteric plane, or you can do it in submucosal plane. You call it as slough. The principle remains the same, that we ligate, completely divide the tract close to the internal opening in whichever plane we can access surgically. If an internal opening is more than 3 or 3.5 centimeter from the anal wards, technically it becomes almost impossible or difficult to reach there and complete this procedure of lift or slough. Therefore, as soon as the internal opening is more than 3 or 3.5 centimeters, it becomes a high fistula, irrespective of the classification of fistula. So the fiber that you use is radial fiber, 360 degree energy will be sprayed from the tip. This is how it will look on the table, and this is a short video. Science is always a good servant but bad master. I don't know if it plays or not. It was just meant to show how we gently move this fiber at 1 millimeter per second. If it can be played, it's okay. Otherwise, it's not a very long video. So if we combine these procedures of lift or slough with laser application, because the inventor of lift has already mentioned very clearly that it is the recurrence only with lift is more than 50% or maybe more. So you need something to do with the remaining tract. you do sit-on, fistulectomy, coring. We are doing laser, diode laser with radial fiber. These kind of tracts where more than 10 centimeter length is there, root of pinoscrotal junction or anywhere in the scrotum, the opening is there. If you perform the conventional surgery, whichever we do, there is a lot of deformity and sufferings for the patient in the postoperative period. You perform the disconnection of the tract close to the anal canal. You can divide, just like we were talking, we converted here also this long tract into two parts. We made an incision in the perineum so that we could pass our fiber from the external opening in the pinoscrotal junction area till this perineal incision, and from perineal incision till the internal opening. So this is how you can divide and take your fiber. Another method to take your fiber is railroading. If the tracts are tortuous, curvilinear, irregular, you are not able to pass, you can pass a fistula probe, just like here you have got this probe here. Take a infant feeding tube of 7 or 8 French, cut the tip of the feeding tube and thread this feeding tube onto the tip of this probe. Pull this probe from here, so this will come out from the external opening here. The feeding tube will come out from here. Remove the probe and then put your radial fiber into the feeding tube. Pull the feeding tube, you can take the fiber anywhere. It slides just like you are passing through a steel or a cement pipe. So this is how you can perform these procedures, and you can see the results, complete healing without needing to remove anything or having any scar whatsoever of sit-on, fistulectomy or any kind of dissection, sphincter repair not required. Similarly, this kind of patient, you can see 10 centimeter long tract vertically, 12 o'clock. At 3 o'clock, an additional 4 centimeter long tract. Both of them had openings inside, separate lifts performed, and this is how the result after a few months. Shorter tract, 6 centimeter. Again, you can manage in the similar manner. No need to do anything else. Just you need to follow the basics, that you put the patient in lithotomy position, just like this recurrent fistula after 1 year of open surgery, drainage, still she had got recurrence. So we put the patient in lithotomy position, follow basics of delineating the tract and identifying the internal opening, spend more time on this, methylene blue, dilute hydrogen peroxide liquid solution, do this kind of probing and then lift 2 absorbable sutures towards the internal opening, divide the tract just lateral to the 2 ligatures, good curettage, 360 degree of the whole tract, not do over curettaging also. When you see the pink tissue coming, bleeding, that means the curettage is done, the bluish granulation tissue has been removed. And once this is done, you can send it for histopathological examination, pass the radial fiber from the external opening till the level of division of the tract, withdraw this fiber at 1 millimeter per second. Usually we keep this ring at 12 watt. You can vary between 12 to 14 watt depending on the chronicity and the fibrosis of the tract, and they heal beautifully. Any configuration of the tracts, you can perform the same thing. So here we have got 2 separate tracts parallelly running, separate lifts performed, and then they heal completely. This is how after 6 months the patient is there. 9-year-old boy sent by a pediatric surgeon, similar kind of procedure. So this is a very good procedure if we combine some division of the tract. You can see here one very important thing for the younger surgeons, fecal contamination of the anal opening. This is what these patients have got in addition to constipation, that is sitting for more than 5 minutes in the loo, which are the 2 factors for causation of the fistula. One is constipation and second is fecal swelling of the anal opening. We need to educate these patients on this. 30-40 years patients, they ask what to do. And I tell them, hire 2 or 3 people throughout the day, ask them to clean your loo, your anus, that will be the best way. See, sit-ons, this is what sit-ons and previous procedures have done. After 1 month of conventional treatment, the edema has gone, inflammation is gone. Once the abscess is not there, we can perform. The right tract was short, we did a laser fistulotomy. On left side, we did a lift with fulguration of the tract, and this is how it progresses, gradually heals completely. Multiple tracts of any configuration, you can do the same. Here there was only single tract which was complete, that was at 6 o'clock internal opening and 5 o'clock external opening. Rest of the openings were only subcutaneously connected. So we did the same. The principle of laser management is spraying the energy on all the walls of the cavity, be it a single tract or a large subcutaneous cavity like this, after debriding it, after curating it completely of the granulation tissue. Once we have done this, from all the openings, we pass the fiber. This is immediate on table picture, and in the follow-up, it heals completely. A very senior surgeon of Ghaziabad, He had undergone multiple procedures over a period of last 5 to 8 years, and still he had these recurrent openings left. Did the same, the lift and then fulguration of the tracts, and it heals completely. He is still doing well. So less than 5% recurrence if we can achieve, this is a very good rate for surgeons. Compared with open surgery, we have got incontinence and recurrence. We can assure our patients of 100% freedom from incontinence. Recurrence, yes, it's still an issue. We are far from ideal. European Society of Coloproctology guidelines are there. They have recommended the procedures for all the procedures for fistula management, and they say ligation of the tract and laser ablation of the fistula tract, they can be considered. They also go on to say repeat LAFT, that is laser ablation of fistula tract, can be considered in patients following failure from the first attempt. Nice guidelines are there since March 2019. They also say the last line is the procedure of laser emitting ablation of the tract can be used with techniques that close the internal orifice of the tract, such as advancement flap, or you can do a lift. Various studies done world over. This term FILAC was patented by manufacturer of a laser company, because of which so many studies were done in the name of FILAC, highlighting its results. But today, as I was hearing some other speaker also, if you do only FILAC for a complete fistula, almost 70 to 80% chances are there you are going to fail. So don't only relying on passing a radial fiber till internal opening and spraying the energy and expecting that it will close is far from real. So one more suggestion, Dr. Tarun, as you are doing a very good job with WAFT. I don't do WAFT in my practice for fistula, but I do use a WAFT scope as a endoscopic procedure for pylonidal sinus. There what we do, the working channel of the WAFT scope we use for passing the radial fiber. We advance the fiber almost 5 to 8 millimeters beyond the tip of the WAFT scope, and then we withdraw under vision so that the lens of the scope is also not damaged, and we are able to do fulguration of the tract also under vision. That is up to us whether we want to upgrade from conventional to newer ones. Thank you so much for the patient listening and the opportunity. Thank you. Yes, please.
What about post-operative care? Is there a need for seeing irrigation?
Yes, definitely. So the healing takes, as you know, 6 to 8 weeks for any wound to heal. So for this period, the patients are advised liberal use of sitz baths, laxatives, and almost 4 to 6 hourly we suggest to them to apply antiseptic ointment with the gauze piece on two sides. That is, one is lift and the site of the external opening. We should also remember to refresh the margins of the external opening after ablating, because on the principles of let out, let the fluid come out. We don't close the incision of the lift, or we don't close the external opening also. Let them remain open, so it heals very nicely over a period of 4 to 8 weeks.
Irrigation of the tract requires
Not at all. It is counterproductive. It's like defeating your own cause. You ablated the tract aiming that the walls of the tract, they close, they adhere to each other. If you are infiltrating anything inside, you are putting your probe, putting your curate, putting your fluid every day, that means it will not close. Yes, very rarely, in hardly 5% or less cases, you might encounter that a good post-operative cleaning is not being done by the patient, or for any factor, you see a drop of pus coming from the external opening or from the side of the lift. There you can recommend a very minimal volume of fluid to be used as an irrigating fluid with the dilute hydrogen peroxide, but not routinely at all.
Neeraj, excellent lecture.
Thank you, sir.
And now, when Giamundo first came out with this procedure of FILAC, he brought out a postulate that as you withdraw the fiber, the tract closes over it. But we did not find that, even later on in many other studies also they found that it doesn't close, it does remain open, and that leads to recurrences. So then, to prevent further sepsis entering into the tract, they started closing the internal opening, they started stapling that, doing advancement flap, and they started adding procedures to that. Okay. Now, if in case you go on irrigating it post-operatively, it again opens up the tract, and that leads to persistence of the fistula. Okay. The question I want to ask you is that in your case, if suppose the recurrence happens, are you going to subject him again to a repeat laser or what? What
Sir,
is your
yes, sir, yes,
strategy for
Yes, sir.
recurrent after a FILAC?
Of course, it is not a generalized approach,
Yeah.
but in almost more than 90% cases, I find this repeating the same procedure is possible, and that is my first choice.
But don't you think so that this procedure has failed? So probably this fistula is not suitable for this particular technique.
So,
Okay.
sir,
So would you not like to use another technique?
Sir,
for that?
I learned my lessons the harder way. There was a young girl who had a recurrence by this conventional, this standard procedure that we follow, lift plus laser. Why did she recur? In those first 6 months of my this practice, because she was bhanji of a very senior surgeon, he requested, please don't get an MRI done. I did not get an MRI done.
Okay.
Subsequent to the recurrence, I got the MRI done. I found there was an offshoot of the tract, another internal opening inside, which on table, despite we use methylene blue liquid probing, I missed it. She had a recurrence. So that is one possibility, that recurrence happens not because we did some suboptimal lift or we did not do a procedure properly. There might be a branch which we missed somehow, or there are recurrences, sir, where whatever we do, some tissue remains, the granulation tissue of the resistant tissue, which is the cause of recurrence, despite following all the procedure standard things that we do.
Right,
So
exactly.
whenever recurrence happens, my intent is, if the subsequent MRI, I do take contrast MRI, even endotracheal ultrasonography for such cases where it becomes a complex thing or a recurrent thing, where I am doubly sure what I am dealing with, and most of the time it works, sir.
Exactly. So that probably proves the point why MRI should be done for
Yes.
a case of fistula,
Very
what we
important.
were discussing in the morning.
Very important, sir.
So that is why we have now changed our technique of doing a laser fistula. What we do when I am doing a laser fistula, I coagulate. After coagulating, I scrape out, because when you burn the tissue or ablate the lining of the fistula tract with the laser, the tissue separates off. It turns into a eschar. This eschar, I scoop it out, irrigate it, and then again I burn it. The second burning, so I do 2 laser application. The second laser application is to induce a low grade inflammation over there, which will later on turn into fibrosis and help in closure of the fistula. Of course, it's very important to disconnect the internal opening from the fistula tract, because if you don't disconnect that, there would be persistent seepage of liquid stools through that, and that will lead to persistent of fistula. Thank you.
So Pradeep sir, thank you so much for sharing your experience. I heard about this and I thought about this double application of laser. So continuing to think about it and thinking whether I should deploy in my procedures or not, what I realized is the difference is in curettage. That is one. If we do a reasonable curettage, we are sure that we have removed the granulation tissue. And in my trainings, usually all these things come into limelight more. I tell them, how do we ensure that we have done adequate curettage? This is the reason. This is one more reason that we should instill methylene blue in every case. Sometimes people say there's a short tract, why do you need methylene blue? It is not only for visualization of the internal opening, a probing can do that easily, but it stains the tract. As you showed in your surgeries very beautifully, when we divide the tract, that central core blue tissue ensure that we have completely removed the tract. So same way, when we do the curettage, the initial tissue is bluish granulation tissue. As soon as we have done this all around, in the end we realize it stops coming as blue, it becomes pinkish,
Right.
and it starts bleeding also, sir. So once we have done this, in my opinion, this is good enough dilatation of the tract. Because if we dilate the tract by repeated curettage, repeated fulgurations, we are enlarging the diameter so much, we may perhaps fail may not get the effect of laser. This is the reason I am not deploying this method, but somewhere whenever required, perhaps one day I might use your method. Thank you, sir.
Thank you.
Neeraj,
Yes, sir.
just to give the attention, very nice lecture. And the initial cases of FILAC, which were done by the German, the inventor, 96% were with the draining ceton for 3 more months before they did the FILAC. So the idea is that you have to drain the sepsis at any cost,
Yes.
whether you remove the internal opening or you
Absolutely.
put a stone. Only then they worked. So alone FILAC, as you also stated, it doesn't work. It's not like a
At all.
pioneal sinus
Not at all.
that you have only tried. You have a source of infection which has to be eradicated, and the message should go that we have to remove the source of infection. Only then the tracts will be we fulgurate the tract or curettage the tract with one.
Yes.
Thank you so much for your nice
Thank you, Dr.
lecture.
Singla. Thank you so much.
Thank you, sir.
Thank you.
Thank you for a
That
wonderful
Goyal,
talk.